Thank you for. I know.
Hello. Hi, everyone. We're going to get started. Thank you for joining us, for those of you that are live and for those of you that are online. My name is Amar Deshpande. I'm the Vice Chair for Education and help organize Grand Rounds. So the reason I'm starting today is we're going to try something new. So as we were thinking about this year's Grand Round series, we wanted to try some new things. And so this is hopefully going to be an exciting opportunity for us to have some interactive discussions with some experts on our faculty. And so you'll hear a little bit from the chiefs about the how the structure is going to work. And please they'll tell you about needing your phones out for the QR code and hearing from faculty discussants as well. So we'd love your feedback after the session is over. We're really looking to kind of create new opportunities to have informative sessions and leveraging the expertise of our faculty in the department. So please let us know how you feel this went and opportunities for improvement. We'll try this again next semester as well. So without further ado, I will hand it over to the chiefs who will start the presentation. Thank you for coming.
Good afternoon and welcome. We're excited to go over this new format with all of you. In the way of introductions, very briefly, all three of us are chief residents. To the residents in the room, welcome, you know us well. But Dr. Michael Dangl received his medical degree at the University of Florida and is now the chief medical resident at UHealth Tower. Dr. Antonio Ocejo received his medical degree at the University of the Sonora in Mexico and was a member of the Harrington training program here and is now the chief medical resident for the Ambulatory Care Center. And I'm the chief medical resident at Jackson Memorial Hospital and came here from the University of Tennessee. In the way of disclosures, we all have none. And now to go over how this session is going to work. So for those of you who do our chairman's reports with us, it's very similar in that we will present a case kind of step by step. The goal of this is to learn from our experts. It is not necessarily to get the right answer or to nail the diagnosis, but it is to learn how to work up these complex patients and to think about it all together. The case is only known to the moderators and the presenters, so the three chiefs here, and the discussants have only received the pertinent topic, so they are unaware of kind of all of the details. We will stop throughout to have our expert discussants weigh in, but this is also an open discussion. So if you have anything that pops into your head, feel free to raise your hand, feel free to jump in on the Zoom chat. We'd love to hear from everyone. It's great when we can have residents and faculty all talking together. There are two opportunities throughout for broad audience participation. So please have your smartphone ready. There'll be a QR code that pops up. It'll bring up a web browser and then it'll kind of populate a word cloud. You'll see it as we get there. So with that, if there aren't any questions, we'll go ahead and get started. I'll bring Michael Dangl up to get it going.
Everyone, thank you for joining us. It should be a fun and interesting case. So we're going to start off with a basic one-liner. We'll refine our assessment as we go, as we learn additional information. So we're going to start off with an 82-year-old male who has a history of kidney transplant, who's presenting with altered mental status. And this is the one-liner that we sent to Dr. Kupin, who's going to be our first expert I'd like to bring up to the case. Dr. Kupin is a clinical professor of medicine. He's one of the transplant nephrologists at MPI, and he directs the nephrology course for the medical students. So we're going to ask for, how would you start off with this case with an 82-year-old transplant candidate with the altered mental status?
Well, I definitely agree. My kidneys were completely blinded to this. I had no information other than what was shown first on that screen. I do have a disclosure, though. I'm completely biased about the kidney. It's the most important organ of the body, and this is not the opinion, perhaps, of the Department of Internal Medicine or UM. But I will do my best to convince you with all types of propaganda how important the kidney is. So here. I have no idea what you picture. Somebody said that was my bar mitzvah picture, but I don't know. But so up to bat. So I'm sure when you saw that first lines that it said 82-year-old altered mental status, kidney transplant, the only words you really focused on were kidney transplant. And so your brain itself, the patient was also confused, but your brain already went into a neuronal frenzy. What are all those intricacies about kidney transplant I have to know about? I've always followed, and we should always follow intuitively, a very careful approach to every diagnosis that we have, and it's called Occam's razor. Razor meaning to shave off all the unnecessary information and follow what we call the law of parsimony, law of simplicity, where we try to focus on the essential aspects. I took Latin in high school for some reason, but I'll translate this for you. Entities must not be multiplied beyond necessity, meaning keep it straightforward. We have an 82-year-old altered mental status, the bread and butter of all of us. But superimposed upon that is that kidney transplants. It could be any organ transplant. It could be a lung transplant, liver transplant, bone marrow transplant. What they really mean is a patient on immunosuppression. So if we were to distill it into its key elements, we have an 82-year-old with altered mental status, we have a differential. We have a person on long-term immunosuppression, no matter what the organ transplant is, and what are the unique aspects that could alter your mental status in that individual. Now, we heard that this patient had a transplant and we merged them two together, and we come up with a differential unique to that individual patient. When it comes to understanding mental status changes, we should term the transplant experience into two phases. The initial postoperative phase, which would not be characteristic of this patient because it's been some years, but characteristic of a person coming out of surgery, the first 3 months, we think of one set of differential diagnosis, someone longer than that, a different set. Let me just take a moment just to review for you post-transplant mental status changes. Of course, we have the operative procedure, pain medicine, sedation, but most importantly would be the immunosuppression. We're all familiar with the psychotic effects of steroids, the neuropsychiatric effects of high-dose steroids. Few people appreciate the important neuronal toxicity of the calcineurin inhibitors. We use tacrolimus, the older days cyclosporin, but they fall in the class of calcineurin inhibitors. Of course, everyone's familiar with tremors, but full-blown psychosis is a clear manifestation of high levels. It's a dose-dependent effect. Seizures at their very worst, and PRESS. PRESS is also well reported now as a consequence of these agents with neuronal toxicity. So levels would be most important for us, but calcineurin inhibitors always must be considered in any neurological effects. We always consider infection, but in 0 to 3 months after the transplant, we don't consider opportunistic infections much. But I do want to stress for you something you may not often consider, and that's infections that came from the donor. So we assume the donor kidney is coming. We always ask about the match, but we don't ask what were the cultures of that donor before they expired. What part of the country did that kidney come from? Could we have exposure to fungal infections, parasitic infections, bacterial infections? So this could manifest itself immediately in the postoperative period. So you can get mucormycosis, not because of all the immunosuppression we use, but it came with the kidney. You can get aspergillosis, not because of the long-term immunosuppression, but it came with the kidney. So infection after transplant is not just UTI, pneumonia, the typical areas, but think of the donor organ as a possible source of infection. Our case is someone on long-term immunosuppression. So it changes the calibration a little bit. We still consider the steroids. We still consider the calcineurin inhibitors. However, if someone has been stable on the same dose of immunosuppression chronically, it would be unlikely that they would immediately have an altered change of mental status acutely unless someone changed their doses. Were they just treated for rejection? Were they just pulsed with corticosteroids? Did they just take an inhibitor of T450 system? Did he wash down his calcineurin inhibitors with grapefruit juice? Did he take all these things could affect the levels acutely, but not likely if it's a stable long-term patient. We have exacerbation of underlying infections, CMV, strongyloides, TB, again, infections that could come with the donor organ itself. And also here, importantly, malignancy. You don't think of malignancy as a diffuse encephalopathy very much. You think of a mass lesion, localized neurological effects, but also we have to appreciate the fact that there are paraneoplastic syndromes related to malignancy. So you have autoantibodies being produced. You could have a global encephalopathy from a malignancy. And who would be at higher risk of malignancy? A long-term transplant patient. So I would rank my patient an 82-year-old. Commonly, it's a UTI. It's an infection. What are the dose levels of his immunosuppression? And then we think of these alternative diagnostic possibilities. So that's all the information I got, and there it is.
Thank you so much, Dr. Pichina, for providing that framework. We'll give you some more information now. So we're going to go through the history of the present illness. So for our patient, the transplant was performed 3 years prior to his current presentation. He's had a 3-month history of progressive decline. Following the transplant, he had been otherwise healthy. He enjoyed gardening, being with his grandkids. He didn't have any difficulties with activities of daily living at home. But for the past 3 months, he's become less interactive, more sedentary, more confused. He's needed help with bathing, needed help with dressing, needed help with preparing his own meals. He's able to ambulate, but he's becoming progressively weaker and spending more of the time in the chair in his bed. So the family had brought him in for that 3-month history of progressive decline about 2 weeks prior to his current presentation for the altered mental status. During that hospitalization, it was a 6-day hospitalization. He underwent CT of the head, which didn't reveal any acute findings, just showed some chronic ischemic changes. He also underwent blood cultures, urine cultures, general infectious workup, which is at the time also unrevealing. So at that time, his altered mental status was attributed to belatacept, and he was transitioned off belatacept, which he had been on for the previous 3 years, to tacrolimus. And even though it was documented that his mental status had improved during that hospitalization, the family, when he's presenting now to us, had told us that he really never had recovered fully, and he was still confused and altered, and they didn't think that he really improved during that hospitalization. But over the past 3 days, he's gotten even worse, to the point where the family says that he doesn't even know who he is, that he's completely bedbound, but he's not having any new fevers, no new coughs, no shortness of breath, no urinary retention, no foul smelling urine. He's not having any chest pain. The review of systems is pretty unremarkable, aside from the fact that he's just being more confused, especially in the last 3 days. He had previously been able to recognize family, recognize who he is, recognize where he is, but for the past 3 days, he doesn't even know his own name. And he hasn't had any recent trauma, hasn't had any recent falls. He hasn't had any recent changes in his medication, aside from 2 weeks ago going from belatacept to tacrolimus. So for his past medical history, prior to his transplant, he just had hypertension. About 6 years prior to our presentation, he had a motor vehicle accident with a traumatic brain injury. He had a prolonged ICU stay, and during that ICU stay had multiple complications. He had bleeding complications, where he was off DVT prophylaxis and then formed a DVT. So he had an IVC filter placed. He also had multiple infections during that hospitalization. He eventually developed a multi-drug resistant organism and required colistin, which caused an acute tubular necrosis, resulting in his end-stage kidney disease. So for his current medications, we'll talk a little bit more about the transplant history in the next in 2 slides. But for his current medications, he's on a pretty standard regimen. He takes Flomax for BPH for the chronic kidney disease, and to maintain euvolemia, he's on a diuretic with Lasix 40 twice a day. And for his blood pressure, he's on losartan 25. He doesn't have any known allergies. For his surgical history, with the end-stage kidney disease, he had an AV fistula that was done in 2015, which is about 7 years prior to presentation. He had the kidney transplant, the donor kidney transplant in 2018. And around that time, he also had ligation of the AV fistula. But aside from those surgeries, he didn't have any other surgeries. For his social history, he was originally from Venezuela, but had been living in Miami for greater than 20 years. He lives with his wife. He has 5 adult children and greater than 20 grandchildren. He's never had any substance use. And then he had been retired for multiple years and previously worked in construction. He hasn't had any recent travel. He doesn't have any pets at home. He doesn't have any new sexual partners. And for his family history, he had dementia in his grandmother, and then also a family history of cardiovascular risk factors with stroke in his mom and heart attack in his dad, but no family history of any cancers or diabetes. So then from the transplant history, the end-stage kidney disease was from acute tubular necrosis from the colistin that he received when he was in the ICU. He ended up getting the kidney transplant at the age of 78. And then he had some more information about I'll just give a general overview about some of these, the transplant specific. So the kidney donor profile index is a general measure. It takes multiple factors into account about that is used to calculate the expected graft length, how long the graft is supposed to last compared to other grafts. So the KDPI of 90% is pretty high, which means that the graft is not expected to last that long. And part of that may be due to the prolonged ischemic time. He had a cold ischemic time of about 41 hours. Correct me if I'm wrong, Dr. Kupin, but I think goal is less than 24 hours.
So cold ischemia time, the time it's preserved, there are 2 ways of doing this. You can put it on ice, not freezing the tissue itself because it'll crystallize, but just cool it down. Your sodium, potassium, ATPase pumps go quiet. You don't expend any energy. And 24 hours would be a pretty reasonable preservation. Here at our center, we're unique because we do pulsatile perfusion of the kidney. We have a machine that actually at 60 beats per minute will perfuse the kidney through the renal artery. with a low level of an intracellular plasma-like solution. And now we can go upwards of 35, sometimes as you see here, to 40 hours. So it sort of prolongs the ability to ship the kidney across the country and preserve it for a period of time.
And then there was a warm ischemic time, about 34 minutes, where they put the graft into the recipient and try to form the connections for perfusion.
Yes, 30 minutes is our goal. I've never been good at putting sutures in, so that's why I'm not a surgeon, but you want to, from the time you take it off the cold preservation to the time you reperfuse it, 30 minutes would be ideal.
Okay. And then the calculated panel reactive antibodies. So these are antibodies that the recipient would have to the donor HLA, and you can see that there was no antibodies. And then in terms of some of the infectious investigation. So for the recipient, he was seropositive for CMV, EBV, and toxo. So it's lower risk for infection because he's already had exposure to those and already formed antibodies. It's higher risk if the recipient's negative and the donor's positive. So in this case, there's no high risk sero discordance there. All right, so he had a pretty standard induction. And then he had delayed graft function with the initial transplant. And then about 3 months after the transplant, he presented to the hospital with elevated renal function or elevated creatinine, and was found to he underwent a renal biopsy, which demonstrated borderline T-cell rejection, which was treated with high-dose steroids. The biopsy also demonstrated evidence of calcineurin inhibitor toxicity. So at that time, he was transitioned from the tacrolimus into belatacept. And so this is about 3 months after the transplant, but 3 years prior to his current presentation. So he had been doing well on belatacept for some time. He didn't have any readmissions to the hospital during that time. His graft function was stable, and he was on a regimen of the belatacept, mycophenolate, and prednisone. And then the belatacept was transitioned to the tacrolimus during the hospitalization 2 weeks ago.
All right, so as we bring Dr. Cupin back up here, which you're welcome to stay in your seat, but at this point, we want to summarize the case as an 82-year-old male who has a history of a kidney transplant due to acute tubular necrosis, who presents with a 3-month history of altered mental status with confusion, slowed speech, and a lowered activity level. The patient was discharged 2 weeks ago after switching off of belatacept, as it was assumed the culprit, but now the patient's mental status has worsened over the last 3 days. So the question to you, Dr. Cupin, is there anything jumping out at you here, and are there any major can't-miss diagnoses that you would want to bring up?
I mean, what jumps out at me is that picture jumping up on the screen. You don't want to frighten the audience, but the important thing is to consider now is this patient's got a rapid decline of generalized cognitive function. So I'm not thinking mass lesions. I'm really thinking of some form of encephalopathy, a subacute encephalopathy, cryptococcal infections, listeria infections. We would definitely, this is a patient to me that needs a spinal tap because with no mass lesions on the CT, we definitely want to see if there's a pleocytosis and do our special cultures. And lots of PCRs are available now for West Nile and Zika and all these infectious agents we have. So I would be thinking globally that this is some sort of infectious encephalopathy that's going on in this patient, barring any biochemical. You didn't show me his liver function, his ammonia levels, his thyroid function, but typically this patient 3 years after transplant, this to me is some type of meningeo effect, encephalitis. So a cryptococcal is still pretty common that we see when we have an encephalitis, but listeria still is there. And but again, in these days, we have Zika, we've got West Nile, we have arboviruses, we've got a whole array of infections.
Thank you so much, Dr. Cupin.
But I just want to add, since you didn't explain belatacept, just for people who may not be familiar with it, belatacept is a fusion protein that inhibits co-stimulation, so it doesn't deplete the bone marrow. It seems to be a better safety profile, but it is quite immunosuppressive. If you can't activate step 2 and your antigen-presenting cells cannot activate your T cells, you are globally immunocompromised, and so you're much more prone to infection on belatacept.
Fine. Thanks, Dr. Cupin. We will go ahead and give you the physical exam.
All right, so for the physical exam, starting out with the vitals, the patient's afebrile, he's hemodynamically stable, and he's saturating well on room air. For his general appearance, he's frail appearing. He also has evidence of volume overload with JVD and bilateral pitting edema. Cardiovascular exam is unremarkable. For his respiratory exam, he has some diminished breath sounds at the right base of his lung. His abdomen is soft, non-tender. He has a right lower quadrant allograft with no tenderness or bruit. He has a stage 3 sacral pressure ulcer without any purulence or any surrounding erythema. And then for his neurologic exam, he doesn't know his name, he doesn't know the time, he doesn't know where he is. He's still able to follow some basic commands. And on the neuro exam, we don't find any focal cranial nerve deficit. He's able to participate in the strength exam, but he's weak on the strength exam. Reflexes are normal and his sensation is normal, but he was too weak to get up out of the bed to assess his gait. So putting it together, we have our history, and we're just adding now that he's afebrile, hemodynamically stable, and volume overloaded without any focal neurologic deficit. So now we're gonna give you the labs and the imaging. So these are going to be the ER labs. So it's not going to be the full laboratory panel. We ordered some additional testing later on, but he has a leukocytosis, which is uptrending and new since his previous discharge. When he was discharged, the previous hospitalization, he had a white count of 13, but no infectious workup resulted anything during the previous admission. His hemoglobin, he's anemic, but that's been chronic for several months. The hyponatremia is new. He didn't have any hyponatremia during the previous admission, and his creatinine is 1.2, which is stable from previous. We have his liver panel there. His liver enzymes have also been chronically elevated for the past several months. And then for the differential of his white count, he has a neutrophil predominance and also some eosinophilia. Very mildly elevated troponin, elevated BNP, very mildly elevated lactic acid, but on venous blood gas, he doesn't have any acidemia. And then his urinalysis for someone who's 82 BPH transplant is pretty pristine. And then we got a tacrolimus level, which was drawn appropriately at trough, and it was elevated at 19.9.
I think we have one person from the audience, Dr. Bodenstop.
Yeah, so just like possibly contribute. That too, that could be contributing alone. But like also he has this brand new hyponatremia and
Speak up a little bit
sorry. Do you want me to repeat myself or no?
from this point forward.
Okay, and the other thing that stands out to me too is the worsening leukocytosis that you said was new for him, and also the new hyponatremia. So he has a lot of things I think going on that could be contributing to the altered mental status with his labs, but the tacro level for me is definitely one of the big ones.
I think Dr. Kupin, you wanted to chime.
So first, what is our expected tacrolimus trough levels? These are always trough levels. Sometimes we get peak levels with antibiotic therapy, but we always look at trough levels here. 4, 5, 6, 7 at the most for an 80-something-year-old person this many years out of the transplant. So we would consider anything in double digits very high and something close to 20 being extraordinary. We wouldn't, if it was, you say drawn appropriately, we would still get someone and put a bright light on them and interrogate them. Are you sure you drew it right? You know, because this is awfully high. And in the setting of pretty stable liver function, that's unusual. Something has to be interfering with the kinetics of Prograf here.
Yeah, it was repeated the next day and was still markedly elevated.
Yeah. And of course, the hyponatremia, you know, again, being a nephrologist, that I'm just thinking hyponatremia, hypotonic, hyponatremia, hypovolemia, all these things. All of you guys should be really excited about that finding. Yeah.
Some other workup that was done in the emergency room.
It's an important point because people get confused about this. So tacrolimus can cause renal failure, but the liver, which is the most important organ in the body, is the one that metabolizes. The kidney, which is the vestigial organ, sort of, you know, can't get hurt by it. But I think people get confused and they think that renal function raises the TAC level, and it's the reverse. So that's why when someone's liver function is worse after transplant, the TAC levels can go up. And in the Hep C era, we would treat their Hep C, we get it under control, and then their TAC levels would plummet because they start to metabolize it. So again, it all goes back to the liver.
So in the ER, some additional tests and imaging that were done in the ER. He had a ECG, normal sinus rhythm, pretty unremarkable. He had a chest X-ray that was done in the emergency room, and you can see that there's a significant opacification of the right hemithorax. So a follow-up CT image of his chest was obtained. Then the CT chest demonstrated a large right pleural effusion with some scattered pulmonary nodules. And then because of the altered mental status, the CT brain was again repeated with no acute changes, just chronic sequelae of small vessel ischemic disease.
So at this point, we're going to turn it to the audience. I hope they can hear me a little bit on Zoom. On the next slide, there is a QR code that you can all scan and start to type in what you think might be on the differential. This can be what's at the top of your differential or other things that are farther down. This will start to generate a word cloud so that we can kind of open it up for a little bit of discussion. Kira, do you have anything that you're thinking about right now?
Yeah. The alk phos was in the 500. Was that elevated that high?
Yeah, so previous hospitalization, it was also in the 500s, and it's been 400 or 500s for a few months. I would say about 6 months previously is when it started to become elevated, but it's been pretty stable of 400 or 500 for the past few months.
So remember, we don't always think directly of the liver, as opposed to some of my colleagues here. Not the first thing that comes to my mind. If I see an older person with alk phos elevation, Paget's disease, maybe some bony abnormalities, and it's especially in a patient after a transplant, there's one other differential you should consider, and that's hyperparathyroidism that we would call tertiary hyperparathyroidism. So the most common cause of high alk phos post-transplant in most of our transplant patients is residual hyperparathyroidism after the transplant.
So as most of you can see what's popping up here on the screen, it looks like tacrolimus toxicity is kind of leading the crowd, but it does look like we're trying to pull two different things. Like, is the acute worsening, is that something new and additional, or is it just worsening of what's been going on over the last 3 months? So I think the biggest thing that we had at this point in the case was, are these two separate entities, or is this all one thing under Occam's razor? So I'll turn it back to Michael to go through the hospital course.
All right, so this is the problem list that we had come up with. We had a patient, 82-year-old gentleman who has a history of a renal transplant, who's presenting with acute on chronic altered mental status, who has signs of volume overload with a pleural effusion, leukocytosis, acute hyponatremia, a supratherapeutic tacrolimus level, and the elevated alkaline phosphatase. So kind of going through the hospital course and providing some updates on what we found. So for the acute on chronic altered mental status, his mental status with treatments of the problems 2 through 5 generally improved during the hospitalization. He was able to that we'll go through each of the problems, but his mental status improved slightly to the point where he was able to recognize his own name. But for the family, he still wasn't back at his baseline. So for the volume overload, it was likely due to missed doses of his home diuretic. They said he hadn't, for the past 3 days, he hadn't really been eating or drinking much, hadn't been taking his medications. But the edema actually resolved pretty quickly. We gave him 1 dose of IV furosemide, and the next day the lower extremity edema had resolved, the JVD had resolved. We got a point of care ultrasound. His IVC was normal diameter and normal variation with respiration. We got a thorax because of the right pleural effusion. We got a thoracentesis, which ended up being transudated by Light's criteria, and we also sent for cytology. For the leukocytosis, he was initially started on broad spectrum antibiotic. The blood cultures initially resulted gram-positive cocci, and then the speciation was Enterococcus fecalis bacteremia, with the suspected source being his sacral ulcer. Because in his urine, he didn't have any signs of infection. He didn't have any leukocytosis and any leukocytes in his urine. So with treatment of the ampicillin, he received a course of ampicillin and his leukocytosis resolved. And for the hyponatremia, it was initially presumed to be hypervolemic hyponatremia, just given his general appearance of volume overload. But even with the diuresis, his hyponatremia resolved. So then we went more down the route of euvolemic hyponatremia. So he was hyperosmolar. So we ordered a TSH, which was normal. And then we performed the 8 a.m. cortisol, which initially resulted as being very low. And then we repeated it because we didn't really believe it, because he was only on 2.5 milligrams of prednisone, which isn't a super physiologic dose of prednisone. But the repeat AM cortisol was also low. for the two checks. So we consulted with our endocrinology colleagues, who said in the setting of his infection and the fact that he hadn't been taking the prednisone was enough to diagnose with adrenal insufficiency. So he started on prednisone 10 milligrams, and with treatment with the prednisone and treatment of the suspected adrenal insufficiency, his hyponatremia had resolved. And then for the super therapeutic tacrolimus level, we mentioned it was drawn appropriately at trough. We repeated the next day at trough again, and it was low. So the tacrolimus was held and returned to goal over the next 4 days. So with treatments of 2 through 5, he got back to being ANO times 1, knowing his name, but he was still not back to where he was before, before 3 months ago, back when he was gardening, he was playing with his kids outside, he was able to take care of himself. So there's still something going on. So we still had this sort of chronic mental status. The acute change in the past 3 days had resolved, but he still had a chronically altered, kind of the same where he was for the past 3 months. He wasn't back to his baseline. And we also had this elevated alkaline phosphatase that hadn't really been evaluated, hadn't been worked up.
On the next slide, we'll have another Slido. We can go to it because I'm gonna read this slide now. So to summarize the case at this point, we have an 82-year-old male who has a history of a kidney transplant with a 3-month history of altered mental status with what we've described before. The acute worsening was likely due to the bacteremia, the hyponatremia, and the elevated tacrolimus levels, all of which have now resolved. And he is back to that baseline of where he was in the previous 3 months, but not this acute worsening. However, he does still have the acute worsening and the high alk phos. So our question to you is, what is the next step in management of this patient? So from what I can see popping up, it looks like a lot of folks do want to further investigate what could possibly be going on with the CNS, both with more advanced imaging and then also an invasive procedure, possibly getting an LP, which I think at this point would probably be safe given that we have CT imaging. And then second is really investigating what may be going on with the liver and moving on to a liver ultrasound. Syphilis.
All right. So
back to Michael.
So we talked with the family about doing a lumbar puncture, but they were very, very hesitant. And so we ended up actually getting a liver ultrasound instead. And the liver ultrasound showed a 10 centimeter mass, which we then proceeded with additional abdominal imaging with a abdominal MRI. And you can see that there was a broad differential of this 10 centimeter liver mass. So at this point, we consulted with our interventional radiology colleagues to get a biopsy of the mass to see exactly what was going on. And the mass ended up coming back as a large cell lymphoma. So at this time, we're gonna call a friend, we're gonna bring Antonio up here to take the case over from here.
Perfect, thank you. Hope you're enjoying the case. So yes, I think we need to summarize the case again. A lot of things have happened, and this is, a good exercise for our trainees, because I feel like it's very important to recapitulate and go back and look at the bigger picture, right, of what has happened so far. So he's an 82-year-old male, history of kidney transplant, we know that. 3-month history of altered mental status, sort of acute and chronic, but he has been progressively declining for a while. So the primary team has treated the patient for E. faecalis bacteremia, that's done. A hyponatremia secondary to adrenal insufficiency, that was dealt with. And now a liver mass was identified in the setting on a chronically elevated alkaline phosphatase, the only biomarker that we had, and initial pathology resulted in a large cell lymphoma. Very, simple. And what do we do next? So obviously we consulted hematology. And the question for the consultant would be, well, what do we do? How do we approach this? have no idea. So I'd like to introduce Dr. James Hoffman, Assistant Professor of Medicine in the Division of Hematology and Associate Program Director for the Hematology Oncology Fellowship. So welcome, Dr. Hoffman. Appreciate your input.
Thank you. Thank you. So I wasn't sure if I was going to be up here before we knew it was lymphoma or after. So there's a couple of things to talk about. We can go to my, nice young, also bar mitzvah. Okay. So a couple of things I'd point out because there's a lot of information I didn't know coming into this. So one kind of small pet peeve is when we call, leukocytosis, in our world, that's kind of, is kind of meaningless, right? Because white cells are high, very simplistic. If you noticed on the differential, it was actually neutrophilia and eosinophilia. So that means something different than leukocytosis. Neutrophilia, bandemia, left shift, you think infection, this guy was infected. Absolute eosinophilia is not something you typically see with an infection, at least not typical infections, certainly atypical parasitic infections, certain malignancies as well. But, something that doesn't apply to this case, but neutrophilia and eosinophilia could be a chronic myeloid leukemia, can be a chronic myeloproliferative disorder. Myeloid lineage includes granulocytes, eosinophils, and basophils. So again, something to think about whenever you guys are giving the word leukocytosis, think a little bit further. So here we have a patient with large cell lymphoma of the liver in the history of a renal transplant patient. If we think a little bit more broadly, we know that our organ transplant patients are prone to cancer. Any of us can get cancer, unfortunately, but patients that have been through organ transplant and immunosuppression are at greater risk. And here's just kind of a single slide that I want to point out a few points. So first, the immunosuppression involved increases cancer risk in several different mechanisms. The drugs that we use increase cancer risk by several different mechanisms. When you suppress the immune system, certain infections, chronic infections, indolent infections can kind of rear their ugly head. There's a whole bunch of viral mediated infections that are a major issue for patients like this, specifically Epstein-Barr virus. Epstein-Barr virus, this is just one kind of very general schema to think about. People are exposed to Epstein-Barr virus. There's a latency period. There's kind of a balance between cytotoxic T cells and the infected memory B cells that just kind of lives happily below the radar. Until you come in with immunosuppression, those cytotoxic Ts get depleted and you end up with a lymphoproliferative disorder. These are called PTLDs, post-transplant lymphoproliferative disorders. Lymphoproliferative disorders include lymphomas and other kind of chronic leukemias. When we think about relative risk for patients with organ transplant developing cancer, you see on the top right a relative risk model. Many cancers are 2 to 3 times the risk in this population. Kaposi sarcoma, non-Hodgkin lymphoma, and Hodgkin disease are particularly increased in risk. Case like this, we kind of already know where this ends up. This ends up with a large B-cell lymphoma, which is the most common type of aggressive non-Hodgkin lymphoma, and a curable entity, curable aggressive lymphoma. I'll say one final thing, and then we'll see where this next slides are going to take us. I'm happy to chime in more. But in the world of PTLDs, there's a spectrum. Sometimes you have some cells that are starting to look a little bit ugly. Sometimes you have cells that are clearly malignant, but heterogeneous in appearance. And then you have these kind of monomorphic PTLDs that look just like sheets of clonal malignancy like you would see in anybody else. And the way we approach patients on the PTLD spectrum has a lot to do with where they are. Those in those early phases where the immunosuppression is starting to lead towards cancer, sometimes you get away with just removing the immunosuppression, letting the immune system wake back up, regain control of the problem. Sometimes you have to gently suppress the problematic lymphoid cells with some rituximab, kind of that middle phase. We can just sprinkle some rituximab, vitamin R, very gentle, suppress the CD20 positive cells, and things can be okay. The bone marrow is the most important organ, by the way, just in terms of the third verse. And then finally, when you have bona fide aggressive cancer, the management parallels the way we would manage it outside of patients like this, combination chemoimmunotherapy with curative intent. So I think with that, I'll stop and hopefully I can chime in.
Thank you. The question, I guess, Dr. Hoffman, would be if you were, because the primary team wanted some direction, I guess. So in terms of the diagnostic testing, you were the hematology fellow, what would be the next sort of
I have
step?
no clue what the hematology fellow would do, but I can tell you what I would do. No, so we have a diagnosis, but classically you have a malignancy like this, you need to do the things you guys are all aware of, like staging, right? Staging, head to toe imaging, bone marrow biopsy. Those are the classic staging, right? All white cells are born in the bone marrow. It's part of staging. I think in a case like this, the one thing I would be careful of is, remember, this patient presented with mental status changes, and the mental status changes exist to this point. Having DLBCL doesn't cause mental status changes. Having a liver tumor doesn't cause mental status changes. So one thing to think about is CNS involvement with an aggressive lymphoma, and that's where maybe re-encouraging of the LP should be considered as part of staging. So for a patient like this, you want to do complete staging, get a sense of prognosis, talk to the patients about goals of care, and then you'd move forward with hopefully curative therapy with combination chemoimmunotherapy.
What about measuring EBV levels, PCR, and monoclonality, SPEPs, kappa lambda ratios?
Okay, good. Well, you're speaking my language with the kappa lambda ratios. So lymphoid cells, lymphocytes can produce antibodies. So certain types of indolent lymphomas, certainly myeloma, amyloidosis, there's a paraprotein. So you're looking for clonality tests in the blood, serum protein electrophoresis, et cetera. The more aggressive lymphoid cancers, like large B-cell lymphomas, are very rarely associated with paraprotein. Pathology will do EBV testing on the specimen. Assessing for EBV in the bloodstream is something that would be done, but isn't actually critical to the next steps in therapy. PTLDs can be EBV positive or negative. There's some subtle differences. It should be tested, but it's not going to drive the management.
Thank you. So the next slide that we have is, are there recommendations that were made by the hematology inpatient consult team? And yes, so they agree with Dr. Hoffman. They recommended a bone marrow biopsy, staging from head to toe. We had a couple of tests that were cooking, the cytology of the pleural fluid that from the thoracentesis that he had, and an MRI with a lumbar puncture. Keeping in mind that we had yet to have the final report of pathology. So having said that, the MRI was the first thing that we ordered. And now we're not, I'm not a neuroradiologist, but I think we can see some enhancement close to the bone, right? So very in a very simplistic way. But what our radiology colleagues told us essentially that he had pachymeningeal diffuse enhancement. That was the gist of it. And also, some findings, he had a TBI in the past, so some hemosiderin deposits, but that was essentially it. So now, when we got the final pathologic report that our colleagues from pathology reached the conclusion of post-transplant lymphoproliferative disorder, monomorphic type. We talk about a little bit about the types, because as Dr. Hoffman said, it's a spectrum, characterized as diffuse large B-cell lymphoma, aggressive morphology. And we have the Ki-67 proliferative index of approximately 90%. The higher it is, the more aggressive, the more rapidly proliferating the cancer is behaving, correct? So I'd like to ask back Dr. Hoffman if, considering the patient's presentation, the altered mental status, sort of like acute and chronic, function and decline for, a couple of months. And as I mentioned, the only biomarker was the alkaline phosphatase that was elevated for like 3-4 months. That was kind of like sitting in the back of our head. Do you think the pathologic diagnosis goes with the clinical picture that this patient has?
Well, I mean, I think you've explained why the patient has been sicker and more sedentary and more ill appearing. We don't have a clear reason why his mental status took a drop. Even some kind of pachymeningeal enhancement, that usually, might cause some meningeal irritation, headaches and stuff like that, but not really an encephalitis type picture. So again, you'd want to know if his CSF was involved, if he had leptomeningeal disease, and that would add some urgency here. The one thing that speaks a little bit against that is 90% of these cells are in mitosis. This is super aggressive. And you mentioned 3-month kind of history of subacute a worsening of mental status. This would typically be more acute if the spinal fluid were involved and this was all lymphoma. So I'm not sure you have a parsimonious story here, but I think logic would dictate that this very aggressive, fast-moving cancer was a big part of the problem, and you'd sometimes just treat and see what happens.
Right, and thank you. And then, I mean, at this time, the family obviously was very anxious when, they were conveyed the diagnosis, understandably so. So can you more or less give us a picture of the treatment modalities, the approach, and kind of like the you spoke a little bit about this, but the prognosis in general?
Sure. So generally speaking, large cell lymphoma, the aggressive non-Hodgkin lymphomas are very bad because they're very fast. And if you don't do anything about them or don't effectively treat them, people don't live very long. But the good thing is they divide so fast that you sprinkle some chemo on them, you can kill them all. Chemo kills cells that are dividing. So the more aggressive the lymphoma, the more likely you can cure, but the more troublesome, if you can't cure. Typical approach for large B-cell lymphoma is combination chemoimmunotherapy, the immunotherapy being rituximab, the chemotherapy being something like CHOP, C-H-O-P, which is chemo, and prednisone. That's all you guys need to know. And so the cure rates are around 60% in terms of all comers, and some can be salvaged after initial therapy. For the very aggressive large cell lymphomas, sometimes we add in some additional alphabet soup to that acronym. Things like 100% mitotic rate cancers that are Burkitt's-like, they have a whole different regimen, Codox M-IVAC, an acronym that, again, you don't need to know much about, but it's more chemo. So again, it would be an R-CHOP-based approach, cure rates of around 60% with all comers, although there's some higher risk features here, so odds might be worse. And obviously goals of care, especially if CSF is involved in a more infirmed elderly person, obviously there's a discussion about goals of care. But this is a curable disease and the intent should be cure.
Thank you. Dr. Huber, thank you.
Yeah, I appreciate your last point. I'm Mike from palliative care. It doesn't matter what the most important organ is, because whole person, patient-centered, and family care is the most important.
I have unleashed a monster with that statement.
So how early would you think there would be a role for palliative care? I was hearing the family was ambivalent about a lumbar puncture, and how would you guide them, given his overall performance status? What is the likelihood that he could get or tolerate what treatments?
So I'll answer that with two parts. So clearly there's excellent evidence that incorporation of palliative care early is important in widespread cancers, morbid cancers. So the short answer is always good to have palliative involved early. In terms of goals of care and performance status, we always need to be careful with that because people can be very, very ill and be cured. So if performance status is being driven by a very fixable problem, that has to be clearly discussed with the family. Performance status in widespread metastatic pancreatic cancer is very different than in aggressive non-Hodgkin lymphoma where there's curative intent. So I think, yes, palliative involved early, a goals of care discussion, clearly focused on the fact that even in very ill people, this is a potentially curable problem. My general bias is to try to encourage family, if it's remotely possible, to at least give a trial of therapy, because within a few weeks, you kind of know which way things are headed sometimes. But if the family is reluctant to go through what is certainly a difficult course of chemotherapy, then those wishes, of course, would be respected.
I just have a quick question, quick statement. So we heard about vitamin R and then chemo, prednisone, but it is important in the area of kidney transplant to realize that the checkpoint inhibitors are one form of chemotherapy that would immediately cause rejection. And so when we deal together with our oncology, hematology, oncology colleagues, we're going to sacrifice the graft if we're going to go to checkpoint inhibitors. And that's almost universal. So, so that would be the one kind of name that you should be familiar with in terms of a kidney transplant recipient of chemotherapy.
Perfect, thank you. So yes, ultimately, the family declined the invasive procedures. So they said, we're not going to go with a lumbar puncture. We're not going to go with a bone marrow biopsy. The follow-up cytology of the pleural fluid was negative for malignancy. Another piece of information. And as we discussed, the follow-up final pathology from the liver biopsy, did not have any further addendums. The PTLD characterized as DLBCL. So eventually the family opted for comfort care measures, and the patient was ultimately discharged home with hospice services. So we felt that the symptoms were explained clearly by the diagnosis, with a couple of secondary diagnoses as well along the way throughout his hospital course, like E. fecalis bacteremia that was treated and adrenal insufficiency with hyponatremia that was also treated. So we have quick teaching points, but I'd like to invite the discussants to give any key takeaway points or any clinical purse if you have something to add. If not, we can proceed with the teaching points that we have.
Yes. The palliation, would there be any role for external RT to the brain in order to slow down the mental status?
So in general, yes, even in a palliative way, CNS radiation could be done, but absent systemic treatment for this cancer, his lifespan is not likely to be long. So I think, the benefits of the radiation versus what it would take, which would be daily trips to the radiation center, probably I would not be in favor of. I would say that this is someone who, if they chose palliative care, I would strongly consider either using steroids, prednisone, or even talking to them about a couple of doses of rituximab, because you can sometimes get into a kind of a quiet phase with good quality of life with very little morbidity. So it doesn't always have to be black and white, treat or don't treat. There's some middle grounds, and that would be, I think, an important teaching point.
Perfect. Thank
Should
you.
we have just let him be? Should we have just let him stay on dialysis and maybe we feel responsible for this? But his lifespan on dialysis at 78 years old is 2 years, 1.5 to 2 years. So we gave him at least 1.5 to 2 years of extra life with his 20 grandchildren into garden. So we have to keep that. It's all relative. He wouldn't be here at this stage if he just stayed on maintenance dialysis for the most part, because those are cold, hard facts. And no, I'm saying, no, but the question is raised: how aggressive should you be in transplanting people who are almost octogenarians? And we do. We look at quality of life, we look at functionality, and he fit every criteria for possibly a pickleball playing, gardening, love of your grandchildren type person. And here in Florida, we do transplant people up to 80 years old. And so.
Perfect. Thank you. So this is just a quick couple of slides. This is meant to be a simplistic review, but we thought it was important to mention, as this clinical entity was the end diagnosis that kind of like put it all together. So we have to remember that PTLD are lymphoid and or plasmacytic proliferations in the bone marrow that act as a complication after solid organ transplantation, but it can also be from allogeneic stem cell transplant, which is far less common compared to solid organ transplantation. And as Dr. Hoffman was saying, this is all the spectrum. There are different types. The one that we had was monomorphic type, right? Which is the most common. Monomorphic because it came from one monoclonal cell or population of cells, right? So those are majority of the cases. We have different types as well: classic Hodgkin lymphoma, polymorphic, non-destructive as well. They tend to be like a little bit more aggressive. So most of them arise from B cells. And as Dr. Hubbard mentioned, latent EBV infection is present in around half or more of the cases. The incidence is very hard to determine. Depends on the transplant center, but it's between 1 to 20% in solid organ transplant, depending on certain factors, type of organ transplanted. Intestinal transplants carry the highest risk, and the degree and the type or how intense is going to be the immunosuppression as well throughout the graft course. The EBV status of the donor and the recipient is important as well, and it tends to present early or late. Early, the first peak of the population that might suffer this condition will be between a year or 2 years, 12 to 24 months after the transplant, or a second peak can appear as a late PTLD 5 to 10 years out of their diagnosis, out of their graft transplantation. As we mentioned, in stem cell transplant, the incidence is far less, but the people who receive a profound T cell depletion to prepare them for their stem cell transplants, they carry a higher risk of EBV reactivation, hence a higher risk of developing PTLD. The cornerstone of PTLD is essentially risk stratified immunosuppression reduction. That is the cornerstone. Sometimes immunotherapy and or chemotherapy, depending on the disease that a specific phenotype, genotype that we were dealing with. But with the approach of using immunosuppression reduction, And I think the interns and residents who rotated through the transplant nephrology service have seen this. 25% of the patients will not need chemotherapy if the PTLD is dealt with just only immunosuppressive reduction, being in an expert setting, right? Specialists who are accustomed to treat patients with allografts. So having said that, this is just the general approach of the frontline setting. PTLD will be the first step. RIS is reduction in immunosuppressant. In coordination, obviously, with the solid organ transplant team. And we can be very simplistic and separate those patients into CD20 positive and CD20 negative. If they're negative, we have to direct our chemotherapy specific to the disease type, right? And that can mean many things and different multiple regimens. But if they're CD20, obviously rituximab therapy would be the next best step. And that's all we have prepared. Thank you so much. Hope you enjoy the case.
So I want to thank everybody who participated. And I specifically want to thank our chief residents who did an outstanding job. We really put them to the test. I gave them an idea that they had to work with, and they created something along with our Vice Chair of Education, Dr. Deshpande. And of course, I have to thank our experts. Even with their young pictures, they were as young in spirit. Dr. Cupin and Dr. Hoffman did an absolutely outstanding job. And I think what was really important is that the attendings in the audience as well participated, Dr. Huber and Dr. Goldberg, and our residents that participated and fellows. And I hope that we can do this again. We won't do it every week, but maybe, I think we said quarterly, right? In the spring, we'll do it again. Please check the chat in order to register for your CME, because if you haven't applied yet, you will in the next month for your renewal of your Florida license. And it makes it so much easier when you have your CMEs all put into the website and you just upload them. So good luck to everybody in that. Also remind everybody that you need to pay your own NICA $250, which you will get reimbursed for. But don't rely on the university to pay for it directly this year. Just pay it yourself and you'll get completely reimbursed. Everyone, have a great day and pay attention to phishing emails. Do not answer the phishing texts.
So